Well, good evening, everyone. Thank you for joining us this evening. I know how valuable your evening time and family times are, so we really want to thank you for spending a little bit and spending the next 90 minutes. I want to remind you this is slated for 90 minutes tonight. And as we go through the presentations and our discussion, we'll be glad to answer as many questions as possible at the end of the presentation. So as your questions, submit them by just typing them into the questions, and we'll be glad to sort them all out and answer as many as we can. So welcome. I want to welcome our esteemed group of speakers tonight. Our panelists for tonight is Dr. Barry Iden from the greater Chicagoland area. Many of you know Barry runs an independent specialty practice with several locations and has been a prolific researcher and author in our industry of specialty lenses for many years. Dr. Trevor Faso. Trevor is from Minnesota, and Trevor is part of a large practice, and he does specialty lens fitting. Dr. Thomas Finley is from the Northern Virginia area. Tom has been interested in contact lenses and specialty lens fitting for many, many years, and one of our leaders in Ortho-K. And then Kate McClure out of Ohio. Kate is on faculty at Ohio State and also works in a big practice where she is currently heading up their myopia management clinic establishment. So thank you to all of our speakers for tonight. Now, many of you have been here and joined us tonight because you've been hearing about something new and something exciting. So yes, you're on the right seminar, but you know, we don't want this to just be a commercial about something new. We're going to introduce you to our new products. But first off, we need to kind of take this opportunity with this expert panel to ask just a few general questions about myopia management and orthokeratology today. So if our panelists will turn on their little cameras, we'd love to see their faces here. There, are we beginning? Is everybody visible? There they are. I see smiling faces. Wonderful. So everyone, thank you again for taking your time tonight to talk with us about this. So let me start by asking just kind of an introductory question to all of you. So where does OrthoK fit into your practice today, and how has that changed in the last few years? Who'd like to start? Come on, Tom, give me a start. I knew he'd hold his hand up.
Yeah, I'll go ahead with the easier one and let the harder questions for the other guys. It's becoming increasingly more and more. I've been doing it for about 20 years. When Paragon first came out, actually, I did it accidentally before that on a bunch of our PMMA and early gas permeable lenses. But I just see it increasing every year. We track our numbers, and every year we're doing more and more of it. We're introducing it to our patients, telling them the benefits of it and the reasons for it. And we're having a lot of patients coming in asking about it. So it just keeps increasing, and we're trying to do more and more of it and as much as possible.
Trevor, how about you? What's happening up in your Northland?
Yeah, so for me, you know, I haven't been in practice quite as long as Tom has, but for me, you know, it's been Ortho-K, you know, since I've been in school has been kind of a passion of mine, and it's something that I'm just constantly working to build more and more of in our practice. For me, it's one of my favorite correction options for myopia in general. But especially for myopia management. So I like to use it for both kind of areas with kids, adults, and it's something that I'm just, you know, trying to build more and more and more of. And as I find that as you get more people in it and they talk about it in the community, I'm getting more people coming in asking for it because they know other people using it and they just like it as a correction option. So I just see it also growing quite a bit each year, having more and more patients of it. So.
Ladies first. Kate, how about you?
So our practice has historically done quite a bit of Ortho-K fitting even before I joined, but recently we've really had a push to increase our Ortho-K fits with our new myopia management clinic, which has been really exciting. So I've been fitting a lot of children, particularly younger children, which has been really exciting. So yeah, it's a great part of our practice, definitely a great practice builder, and we utilize it to its full advantage, mostly for children, but certainly I have a fair number of youth and young adults and older adults in it as well.
And certainly not least, but last, Dr. Iden,
Yeah,
how's it in your practice and how's it changed?
well, yeah. So I guess Tom and I take up the elderly statesman roles here of the evening. And probably some of my patients that we've fit, and I'm sure Tom would agree with me, are younger than Trevor and Kate are. So, you know, and have been in their lenses longer than they've been probably alive. In any case, we also got involved very early, over 20 years ago, in some of the preclinicals for Paragon CRT. And that led to our involvement in myopia management very early on, because we kind of saw that that was really the ticket to success for corneal reshaping in Ortho-K. Many of you may know that we were involved in putting together the SMART study on one of the early myopia management studies using Ortho-K, and the Euclid lens design, the Emerald lens design, was the design of choice and used. And that's really how I got involved in such a significant way. The vast majority of our patients are in fact younger patients involved in myopia management, but we have patients as old as in their 60s actually doing corneal reshaping as well.
Absolutely. You know, I'm in a position now, and since I left the university a few years ago working here with Euclid, I get to attend and listen to a lot of webinars, and especially over the past year with the pandemic. So, you know, I got to tell you, I've been doing this 35 plus years, but I'm a little confused right now. I hear people talking about treatment zones, where another one's talking about corneal treatment, and another one talking about back optic zone diameters. So I think it's confusing for me. I can imagine we have a lot of young practitioners on this call. So let's talk about, I'm going to put up a picture of a topographer here. So I think I have to go back to share. You know, Barry, can you start by just looking at this topo? Give me your idea of where we're impacting treatment for myopia.
Sure, be a pleasure. So it is interesting. We don't have agreement. We don't have consensus on this terminology in this field. And I think that's something that we all probably should dedicate ourselves to doing. If one is considering a treatment zone being the area that the cornea is being flattened by the lens, then you have to look at the area of change of curvature, change of shape. So on those topography difference maps, green reflects no change, blue reflects flattening, and warmer colors or red reflects steepening. So one would have to say that the area of blue is the flattening zone, or if one wants to use the term treatment zone. But in my mind, it depends upon what you're doing with these lenses. What's your goal? If your goal is for myopia management, then we all know that peripheral myopic defocus is the key. And really the treatment zone is the red. And it has to be within the pupil to have the effect, right? If one's goal is to temporarily reduce myopia for vision correction, then the treatment zone is the blue zone. That's how I would see it. But the truth is we should all get into a room, open up a good bottle of wine, and make a decision on this.
That would be a good thing. I think, you know, this is, especially orthokeratology, it has grown so fast. And as I go around to different academic situations, you know, I hear people using different terminology. So, you know, Trevor and Kate may comment, Ohio State may be teaching one set of terminology while Michigan State at Ferris may have taught Trevor something different. So we do need to find some consistency. Are we talking applanation zone? That's the area for treatment for the distant myopia. Are we talking about the whole entire, as you said, the red ring, or is it half the red ring? And what's in, you know, inside of the pupil? That's myopia management. Anybody else have a comment on that? I just think it's a point of confusion. I thought we'd use your time to mention. Tom?
Well, there's been a lot of discussion online about the treatment zones, and looking at this topography, I think most people would agree if they have a Ortho-K patient coming in with this type of topography, looking at it first glance, we're going to be pretty happy. However, I've seen many patients where the topography looks beautiful, but we're not getting the results. We're not getting the refractive results, or the lenses may not look good on the eyes, and vice versa. We may get a topography that doesn't look quite as good, but the patient's doing wonderful. So I think it's one piece to the puzzle, but we really don't want to focus on just one area of an Ortho-K lens. We want to look at the overall patient, and are we getting the results that we're hoping for, and are the patients getting the results that they're hoping for, and being comfortable and able to see.
Mhm. Well, thanks for the clarification, guys. It certainly helps me to be able to think. I just thought, I have a lot of people saying, oh, well, this back optic zone diameter. And I'm like, what does that have to do with anything? It has something to do with it, but it's just a side-to-side measurement of the power curve. So I think hopefully we can start a conversation to clarify this. Here's my next question. Here's another point of confusion for some of us. Most Ortho-K designs today here in the US use what is called a Jessen factor. And that Jessen factor is usually a +50 or +75. Can somebody tell me what this Jessen factor is? And do you use it as a parameter that you change for certain patients? If so, when would you change it? I mean, it's a parameter the companies can change for us. When and how do we use that? Barry, I see your head nodding. You want to start?
My pleasure. You know me, I'll always jump in. Never a problem. I typically don't change the quote unquote Jessen factor, which is the overcorrection factor that allows for regression, correct? And so we know that most of the designs out there typically +75, +1, maybe +1.25, so that they're a bit overcorrected in the morning when they remove their lenses. As the cornea starts to kind of reverse its shape back closer a bit to normal, we are sure that by the end of the day, they're still getting a good vision correction. I think modification only depends upon the patient's subjective symptoms and what we find. So if a patient says to us, gee, I'm doing great, but boy, at night when I drive home, I think I need some glasses. Well, I'll have them back at the end of the day. I want to measure what we're concerned about. If you don't have the measurements, you don't know what's going on. I'd look at the topography, I'd look at the refraction at that particular point in time. If they need some more correction, you have to consider a number of factors. Is it a young person who can handle it through accommodation earlier on to be overcorrected? Or am I dealing with an adult who's perhaps even in their late 30s or 40s or even presbyopic, where that can be a real problem to overcorrect? All of us, and Jane, you and I are in this group, we are surely presbyopic, and there is nothing worse for a presbyope than to be hyperopic. That is the worst, I can tell you. So as all of us look forward to cataract surgery, that's the thing we got to avoid. So that's part of how I look at things. I'd rather give an adult a pair of glasses later in the night or later in the day that they would drive with if need be, rather than overcorrect them earlier in the day. A young person may be totally different.
Trevor, you got a comment? I see you.
Yeah, I would agree. The typically to start off with, I don't play too much with the Jessen factor, but it is something that looking at a patient that, after a while, if they come in, and again, this will be more often with adults, 20s, early 30s, maybe late teens, whereas, if they come in and they're like, they're reading 20/20, but they're like, it's just not quite as nice as it has been. I'll usually demonstrate to them, kind of like a loose lens over refraction of -1/4, -1/2, -3/4, just so they can see, what does that do? And oftentimes, if they're like, wow, that makes my vision just really pop, that gives it that extra little enhancement. Then I'll have the lenses redone to add that extra little bit of, kind of wow factor to just overcorrect them a little bit. So it just makes things, kind of gives them HD vision a little bit more, adds a little bit more definition to things. But otherwise, I think, from a myopia management standpoint, the only reason I do that is if, again, looking at our treatment zones, like we were talking about, if you're looking at a treatment zone and you aren't seeing that amount of, like maybe the ideal amount of myopic or the plus correction in the periphery, then you can adjust the Jessen factor to increase that a little bit more too. But I haven't really had to do that too often. Most of the time it's with an adult patient and they just want a little bit more like boldness to their vision is when I've made that adjustment.
Yeah, I was just saying I have had a couple of kids who just seem to have rapid change of the corneas. And, when that's been a place I've used Jessen factor. That's the only, that's it. Okay, let's talk about, I want to touch on toric lenses a little bit. Kate, any idea how much, how often do you use toric lenses? Is it a big part of your practice?
Sure, thanks, Jane. So I would say that it's approaching about 25% toric fits, and that's increasing rapidly. I think it's because the designs have become much more effective and much easier to use. So in the past, I've shied away from fitting children with astigmatism because I said, your child's not a good candidate. I don't think this will work well. But now I'm actually excited about the challenge, and I will fit a child that has astigmatism correction because I've had a lot of success with the toric designs, specifically the emerald toric. So about 25% of my patients right now are in a toric design, and it's even increasing, which is really exciting. And I've had a lot of success with first lens fitting with these patients. So it's made it really easy for me.
How about you? What's your practice look like today?
I'm a lot higher, and I don't have an exact number, but I bet about 50% of our new fits, and even we're switching over, are going into toric lenses. And it's not so much the refractive astigmatism, but when I'm looking at the topography, and just in the last couple of years, I took a couple webinars on our topographer and was sadly shocked at how much I learned about topography, where I thought I knew a lot about it before that. But just learning how to interpret the topography and looking at the 8mm chords and the differences in the curvatures 4 millimeters out from the optical centers, I'm just finding more of our patients are doing a little better with the toric design.
Let's talk about empirical ordering. How many of you do empirical ordering at some person? I know some. Okay, Trevor does for sure. Yeah. Okay. So, Trevor, why do you see empirical fitting as fitting into your practice?
I love empirical fitting. Just being able to grab the information, kind of put it all together and just ordering a lens, for me to start off with, just saves a lot of time. It gets, and so oftentimes the first lens, is just a lot of chair time. The patients do a lot better. They're a lot happier with it right off the bat because it works better. But then I also find, like, when it comes to making adjustments, I love working with the consultants. And that's, kind of the easiest way to do that is through designing that way. And so I like working with the consultants because, to be honest, I find the more they do, the less I screw up and the easier the whole process is. So it keeps everyone happier.
They make us look a lot smarter, don't they, Trevor?
Yeah, well, you guys make me look a lot smarter. So
how about the online calculators that are coming now? You put in the data and you hit a button and it tells you what you're, anybody using those, or what do you think? Is that a good kind of, you think that'll help? It kind of takes empirical fitting to that next kind of step. Barry, any comment? Yeah, go ahead, Kate, and then we'll go to Barry.
Yeah, I haven't used any of the calculators up to this point. I do like using a consultation and sending the HVADK's topo. That way, if there's anything that I happen to miss or anything else they see, they can ask questions, where a calculator is just kind of spitting out information. So having that second point of contact, I think, is really helpful. And I really promote that to my patients. I am custom designing a lens for you. So if you use consultation and send them the information, I think you'll be a lot more successful than just using a calculator personally. I think a calculator is appealing. Staff could do it. It might potentially be quicker, but using consultation and sending them the information is so quick that I just have a lot of success with that as of now.
Let's talk a little bit about materials of lenses. I feel like today that gets overlooked a lot. I came into the industry back in the time where we were just moving from PMMA, and we had, this variation and that and HDS in Boston, and and it was just, it seemed like every time I turned around there was a new plastic, invention coming out. And we've been in kind of a quiet period. How do you guys see lens material, and what characteristics, if any, do you look for in your lens material choice? Especially for overnight wear. Does that make a difference to you? Tom, you want to tackle that one?
Yeah, I'll go. Yeah. Well, I think the more oxygen you could get, more oxygen permeability, the better it is, especially since they're sleeping with it at night. And it's just going to be safer for the patient. We have to make certain that the material wets. If you think back to the earlier silicone lenses when they came out, that was the biggest issue. They breathed, but then they didn't wet at all. So you're always looking for better wettability, better oxygen transmission, good optics, and then durability. So it's nice, and it's nice for us to be able to offer to our patients, hey, there's a new material out that's going to be safer for you, and I think you're going to find it works that much better and will be better for it. So it's nice that we get to be the good guys to offer it to our patients.
Barry, any comments on plastics, how they've changed?
Yeah, for sure. Again, dating us, living through all of the material developments, I remember as we started coming out with higher and higher DK GP materials, there was always a but associated with those new materials. They didn't wet as well, they weren't as stable, they flexed more. And there was a point in time when I remember learning that if you had certain types of corneas, you don't want to use high DK because they wouldn't be stable enough, or they would flex too much, and so on and so forth. But with the advent of the newer hyper DK materials, it's a win-win situation. These lens materials are as stable, they're as wettable, but they give you the additional oxygen transmission. So the bottom line is, why wouldn't we want maximum oxygen transmission as long as we're not giving up anything else? And the answer is, of course, we would want that. And I think we can get that these days.
Yeah, so Kate, in all your discussion points with parents, is the material a discussion point, or is it just the brand, the company that you believe in will support you? How do you present it to your parents?
Great question, Jane. So I like to communicate with my parents and explain to them exactly what I'm doing and the value of the product that they're getting. So I once again explain that it's a custom design lens made out of the best, healthiest material option that we have available today. And parents get really excited about that. They like hearing oxygen and healthy. So when they hear those words, they feel even better and more confident in your Ortho-K fit. So it is something important to communicate. You always want to advocate the services that you're giving and what you're providing. And I think just a little brief explanation can go a long way.
Well, at this point, I want to thank you for all your general comments. We're gonna let you guys flip off your cameras for a minute, and we're gonna talk a little bit more about the new offering tonight we want to discuss.
I've got a couple of PowerPoint slides I want to share with the audience. You've heard our discussion already about why we might choose a DK, not only a high DK, but I want to get into that hyperspace area. I want these children and their parents to be assured that the physiological advantages that I can reduce the edema as much as possible. There are studies that tell us that a healthy cornea is the easiest one to fight off infection. So that's important too. So why have we not been choosing? We've been, using very adequate lenses, but certainly not these hyperoxygen flow lenses. And that had to do with what Susan just mentioned. Poor wettability. It often required specialized surface treatments. They tended to deposit. Maybe they flexed, they warped. They needed to be replaced and cleaned specially. So we've had this kind of, we wish we had it, but we couldn't get it. So tonight, I want to introduce you to Euclid Max and Euclid Max Toric. Now, Euclid Max and Euclid Max Toric are going to be complementary products to our 20-year existing time-proven performance of Euclid Emerald and Euclid Emerald Toric. So many people said, "Oh, are they going away?" Absolutely not. They are there and they will be there as always for you and your patients. But we're introducing Euclid Max and Euclid Max Toric in the U.S. Tonight, and it will be quickly followed in some other markets. And then over the next few years, Euclid will be rolling it after we get approval into the 20 individual markets that we service. Now, you'll notice when that popped up there, it said Tisofocon A, and a lot of people ask me. Now I'm putting back on my Polymer Technology hat for a few minutes here, and let's see if I can explain how basically 3 different companies and 3 different materials are carrying the same, what we call a USAN name, which is the government's approval name. And what they're approving is the recipe, the fundamental building blocks of that plastic. And as those are what we call monomers. So how much of each one you put in there, and then how you make it become solid, or what we call polymerization. Now, back in the late 1990s, our friends over at Minicon, if you remember the late 1990s, you'll know that was a time where we were all pushing to get these hyper silicone, high decay soft lenses so our patients could sleep in them 30 days at a time. Well, it took us a few years, but we learned the lesson that that might not be the best thing for most of our patients. But Minicon approved a material called Minicon Z. It is currently FDA approved for up to 30 days of extended wear. It requires a very specific plasma, a little more extensive plasma treatment to improve its surface wettability. But, it's been there and it's used in many different markets, including here in the US. Now, in 2018, our friends in Europe at Contimac took that same basic formula and they said, we think we could take this formula and make some changes to it. And so they did some polymerization and mixing, so same general material, same recipe, but in various arrangements, in various amounts, different polymerization. They came up with a material that is approved for daytime wear only, but it did not require any plasma treatment. It seemed to wet very well on its own, and many of you know that in your daily wear GP patients. Well, over the last couple of years, in a partnership with Euclid, we've been able to go to our US FDA, and we have received exclusive approval to utilize that material for overnight orthokeratology. Now, it's only available through Euclid. It requires no additional surface treatment, and it allows us a hyper decay with a better balance of some of those properties. And those properties, some of them we've already mentioned, but properties include things like first fit success. We talked about empirical fitting, and many of you know that our internal data tells us that 87% of the lenses are only ordered one time. So excellent, minimizes our chair time. Dr. Mai mentioned that, gets patients satisfied quickly. We have to have good wetting. These are lenses that live in a tear film. The front and back of these lenses are coated with natural tears. They have to be able to wet well. We all want that hyper decay. And we want that because these are young, healthy eyes, and they could potentially be wearing these lenses for 10, 12, 14 years. So we want to make sure we give them as much margin for safety as possible. And of course, as far as the lens characteristics, we want it to be stable. We want it to be durable, to resist any warpage, scratches, chips. These are, in our lab, these lathing cuts are at the sub-micron level. That's how tightly we control them. And so if a lens bends or warps, then we lose some of the effectiveness of our design. So we need something to produce you the highest quality lens, and we need that reproducibility. Now, people ask me about the clinical outcomes. There's a few studies here, and I just put them up on a slide. We'll be glad to give you the references if you don't take a picture or whatever. One of them was done by Lum and Swarbrick, and they were looking at how much oxygen getting to the cells, and would high DK improve the cellular metabolism. And what they concluded was that it would, and it would probably therefore promote faster shape changes in OrthoK. We get better, quicker clinical response, according to their theory. The author actually made a quote that in high decay materials should be used for overnight orthokeratology, not only to provide the physiological advantages of high oxygen flow, but to also improve our clinical outcomes as far as shape changes. And then several different studies, we've listed 4 of them here, seem to come to the same conclusion that higher oxygen flow is, it keeps the cornea healthy, and it keeps tight junctions, and that results in a potentially reduced risk of infections. So 2 clinical reasons that we want to look at higher oxygen permeability products. Now, for those of you who like to read labels, here is what will come if you order a lens. This will be in your package. It gives you all of the different things. The DK value here, as the FDA has accepted and given us, is 180 DK. So it's a hyper DK material, and that is using the polographic method. You'll see wettability. I have to tell you, it's almost impossible to compare different materials because there's about 4 or 5 different ways to measure it, and they all give you different numbers. Some of them have advancing angles and decreasing angles. This one is the Cecil drop angle, and I'm just going to tell you that higher numbers are better in that measurement. 90.7 is considered excellent wettability in that measurement category. All of the other things you see here, I'm just going to drop down to next to the bottom because this is always important. This product is available to you in both blue and green colored tints. Now, remember that Euclid puts a unique identifier. We laser mark it into the edge of every lens, so we can tell you every lens, where it came from, who it's for, what the parameters are, and what day we made it. But to help the kids and the parents, you can color code right and left with blue and green. Now, the final thing I want to tell you about is real quickly, we started giving selected practitioners access to this product about 14 months ago. We selected high volume OrthoK fitters, but we selected some newer practitioners as well as some of us that are more seasoned eye care practitioners. And this was real simple. We said, we're going to give you access to this material, and we want you to fit as many patients as you can. We don't care if they're new fits and never had a lens on before, or if they're refits or just annual replacements. If you will give us your clinical feedback on durability, wettability, comfort, deposit resistance, and ease of cleaning. Now, we're still collecting this data, but I want to give you the early snapshot. This is 144 patients. And it says percent of satisfaction. I'm not sure that's the best word. It may be percent of ratings. But you see here, out of the 0 to 100 scale, 95.8% rated the durability at 95. Surface wettability also ranked very high at 95. Comfort, so just impressions of comfort coming back from their patients, was at 95%. Deposit resistance, patients are different, tear chemistries are different. You can expect some deposits. So, but it wasn't much, 86.7. And if they did get deposits, ease of cleaning ranked way up there at 90. So they seem to be fairly easy to manage in a child's hands. So the key findings from our practitioners in this group, 100% of them are telling us that they would recommend Euclid Max for their next Ortho-K patients, and that in their opinion, it offers better or equal comfort to whatever they've used previously. So, if we can give them 3 times as much oxygen, or whatever that number is, I don't want to say it's 3 times because the percentage may be wrong, but if we could give them a hyper DK and not have to trade off other properties, we want the balance of properties to be what we need in a clinical setting. So that is Euclid Max, what we hope you'll see as a breakthrough for overnight orthokeratology. And again, available in both the spherical and the elevation specific Max toric design. Now, let's see where we're at. I also wanted to mention to you that you can now order this product anywhere in the United States by contacting us at the phone number or the email below. Our consultant staff is always there if you have other questions. And I'm proud to say that we believe so much in this product that we are offering you a no risk, 100% satisfaction guarantee. Now, what that means is if you try Max and you or your patient do not believe that it's what it is or that you like it, if you don't like it, then in a period of time, we're going to give you a period. I've forgotten what it is. Your salespeople can help you with that. But we will remake that lens of identical parameters in the Opera Focon A, our tried and true material. So you have nothing to risk here. We're hoping you try it. We hope you're as excited about it as we are, and we're willing to give you the guarantee to back it up. Now, I mentioned your sales team, and I do want to bring these 3 important faces up. I'm sure most of you have received phone calls or emails from them. And so please, you can call our 1-800 number and we'll put you in touch, or if you can get directly in touch with them through sales at Euclid. Okay.
I'm finished talking about Max. I want you to tell us a little bit about your experience. Each one of our panelists tonight have been involved in the early access program. And so let's have each one of you give us a quick impression. So let's start with Kate. Kate, what was your impression of Euclid Max?
Sure. I've really enjoyed using the product. I actually forget which of my patients are in the new product versus the old material, which I think is actually a really great thing. If it's just as good as far as how the surface quality of the lenses look, how well it's treating the cornea, and it provides more oxygen, I think that's a big win. So it's performed very well in my practice, and I've really enjoyed using it up to this point.
Barry, how about you?
Yeah, I would concur 100%. To me, the success of this material is not realizing any difference. So if we're prescribing it and I'm not hearing anything or seeing anything bad, then it is a win situation. That's the way I looked at it.
That's true. Sometimes what you don't see is a wonderful thing. Absolutely. Tom, how about you? What's your impression?
It's for us, it was seamless. Now we got into the program a little later, so we didn't have as much hands-on experience. But again, it was seamless. What I liked about it, the fact that, as Barry and Kate were saying, no problems at all. But again, being able to offer a better and newer material to the patients. Parents of these patients are extremely knowledgeable. And the last thing I want them to do is come in asking me about a product that I haven't offered. So one, it was seamless for us. It was a win-win for the patients and us. And I'm looking forward to working more with it.
That's an interesting comment, Tom. I hadn't thought about, but these are generally young parents, and they're in a high-tech world. They're always looking for something new and better. Technology has changed so rapidly in these generations. That's what they look for. They don't look for something necessarily that's, we were using a few years ago. They just think something new must be better. I hadn't thought about that. Trevor, how about you? How'd you find it worked in your practice?
Well, I found, so I think I offer kind of like a slightly uniquer experience with this, because not only do I fit my patients with it, but I've actually been wearing the Max lenses for a little over a year now. So I've seen it actually from both sides. I've either refit all of my patients wearing the Euclid Emerald lens into the Max lens. And then, like I said, I've been using it myself with my patients. They've all done great. Again, like everyone else said, it's been like pretty seamless, no complaints. Everyone's looking great. They're happy. They're doing well. But then I got to actually see what it's like just from, my own perspective in terms of using this lens over a year. And I definitely noticed kind of a difference. It was very comfortable. It felt about the same, if not, maybe a little bit more comfortable to me. But one thing that I've, kind of looking back on the last year, one thing that I actually noticed is my vision was actually more consistent every day when I'd wake up. Every once in a while, I used to always have with my previous lenses and other designs, every once in a while you'd wake up and one eye would just kind of be like a little off. And, I was kind of used to that it's like, oh, it was just kind of a bad night of wearing that lens. Something must have been a little wrong. And I don't really have that anymore with this lens. And it could potentially just be the, potential a little bit of corneal edema that you don't get quite as much of now with a hyper DK material. But that's something that I noticed. And I think, especially, little kid patients, they don't really notice that stuff, but adult patients, I think, are going to notice that more often. Now myself, I've noticed that over the last year by wearing the material. So.
Interesting. Any of you have comments that patients have made? Any problems with deposits, with cleaning, with some of the things we've seen historically with these higher DK materials? You're using the same solutions. How about that? Any change in solutions, anybody?
Jane, we haven't changed a thing. We want it to be a seamless experience. In fact, we just simply say it's a new material that has more breathability. And we know that this is logically a healthier option. It should create no other changes for you. And so far, we haven't heard any negative or honestly any positive feedback which is fine by me. It's totally fine.
Jane, it's been pretty easy in my practice as well. I use ClearCare for all of my Ortho-K patients, and I think that that's also a great solution for this hyper DK material. So using ClearCare has been very successful. I feel confident that the lenses are clean, and I know it's safe to use with all materials. So that's been pretty easy as well. So I really advocate for hydrogen peroxide solutions for my patients.
And Trevor, for yourself and your patients, no problem getting to, most of us recommend annual replacement. I think that's become kind of standard of care. No problem. This isn't a surface treated product, so you don't have that breakdown. Any problem with getting to a year for any of you that have those patients that have been around a little longer?
No, and when because I just got a brand new pair of lenses myself like a couple weeks ago, and I didn't even notice a difference going from the set that was a year old to the brand new set. It was a very seamless transition in terms of comfort as well as my vision again. So.
Great. Oh, we gotta answer some questions. That's what we're gonna do that. But I have one final question for our panel here. And then we've got a bunch of questions from our attendees, and those are the important ones. So, we talked about at the beginning of this conversation about orthokeratology and high DK materials in their past. So it's been utilized, OrthoK has been utilized around the world for over 20 years now. Tom mentioned how, he and Barry and I started 20 years ago with some of the early studies. So how do you see OrthoK in the future now? Put on your thinking caps. Where do you see it going? What are the next generations? We've seen now Euclid Max bringing us something new and different. What are the next generations, the next thoughts that you think we need to look at to continue this evolution in myopia management with orthokeratology?
Jump in, Jane, if you don't mind, to start out the conversation. In my mind, there's a number of areas that I think the future is probably going to need to go in this area. First of all, as you alluded to before, more of the empirically more sophisticated fitting with even higher success. Now, that being said, having 87% success on first lens with Ks, manifest, and corneal diameter is pretty mind blowing and pretty amazing. And actually, it was the success that we had with that simplified method that had us changing from diagnostic lens fitting to empirical fitting many, many years ago. It has so many advantages: efficiency, accessibility, and acceptance even by the patients and the families. But I think as we move to the future, we want to raise that number well into the 90s, maybe into the high 90s. I think that's going to depend upon new algorithms that are going to be corneal baseline shape dependent. And I think more than doing an online put in your information kind of situations, I think that they're going to be more automated, where we take the topography information, the refractive information, maybe even things like pupil diameter and maybe even higher aberrations in the baseline system. So many things we can think of that can go into that kind of that formula that can be automatically incorporated into the most optimized lens fit. So that's number one. I think we're going to see that happening, and we're going to have software programs that will do that very, very soon. The other thing is going to be to make it a more acceptable modality. And one of the things that I'm hoping for, and we've heard about this over the years, is more prolonged effect. So perhaps if there's some way, whether it's with pharmaceutical agents or otherwise, that a lens can be placed on the eye for one evening and have that effect last for far more than one night or one full day, so that maybe a patient can wear a lens once a week or perchance once a month. I mean, if we can dream, why not dream big, right? So I think those kinds of things are really exciting for the future.
How about you? Any thoughts?
You say me?
Yes, Tom. Sorry.
Well, it's the nice thing is it's becoming more and more commonplace too. So years ago, I would spend more time just trying to explain exactly what Ortho-K was, because it was so the opposite of anything anybody had heard about. So as it's becoming more commonplace, more people are interested, and they're hearing more about myopia and this epidemic that's going on. So it's nice to have a solution that we own right now. So hopefully we're going to continue. And as Mary said, it's just going to keep evolving, just as we evolve. This is like the Wild West, and I don't think we're just touching the tip of the iceberg, and it's just going to get better and better for everyone.
Yeah, that's a good point. I think it's, just a few years ago, I would mention orthokeratology to another practitioner, and they'd say, oh, nobody wants that. Or, none of my patients are asking me for it, so it must not be something I need to learn. That's really changed in just the last 5 years. It really has. Trevor, how about your comment? Yeah, anything?
Yeah, I mean, I would agree. One, kind of like what you and Tom have said in terms of just as word of mouth kind of spreads. I mean, I can think of 3 examples in the last 6 months where, to start off with, I had a mom whose daughter I fit in October, went so well for her. Mom came back and wanted to get fit, so I fit her. Then I had another girl who one of her classmates wears them, and she was like, I want to wear them. So she came in, she did so well. Then her mom came and wanted to have it done. So I've gotten 3 new patients just from like classmates and their kids doing it, and they just all want to have it done, and they've all done very well with it. So I think as it expands in the community, and more people learn about it, and just kind of learn being safe and just being a nice option, that's going to expand. But similar to kind of what Barry was talking about, where just increasing that success rate I think, a big part of what's going to impact that is as the technology for like the accuracy and consistency of our of our topographies improves too. Just in terms of some of the variabilities there that you can get with tear film fluctuation and things that way. As that improves, that's going to also improve our ability to get just these baseline scans and be able to be more accurate and be potentially even more specific to a patient, to make them more customized than they already are. So as that continues to improve, I can see that, these are going to be, they're already highly customized, but they're going to be, hyper customized, I guess we'll go with the theme. And as that continues to grow on, and also as, the idea of myopia management continues to progress and becomes more wide known, especially with all the new, there's lots of different things coming out now promoting myopia management. As that grows more and more, for me especially, I think, Ortho-K is just going to be like the frontline method of it. It is my preferred method for myopia management, just because of whether they're wearing the lens or not, they have that full-time myopia management effect when the lens is there as compared to some of the other modalities. So I can see it just increasing further and further that way as that grows too.
Yeah, Kate, we talked about the ease and you guys spoke about the empirical fitting, but I do hear from each one of you, of course, that saves us chair time, and it's an impressive thing to our patients when we hit it right the first time. But we're also moving into a generation where practitioners have to be more knowledgeable of all the parameters. I mean, these can be as patient specific as a doctor wants them to be. You can be as much in control. So I can see this kind of, there's an evolution of maturity coming in practitioners and their understanding of lens design. Do you see empirical fitting? I take it is still, and it will be an important part of your practice, but do you find yourself, learning and wanting to kind of tweak this and adjust that a little bit more? Because to Barry's point, if 87% is successful with the empirical, I want it to be 97%. I'm just one of those people. How about you?
Absolutely. And the more fits we begin to do, the more troubleshooting we'll have to do as well. If you have a larger sample size, you're going to come across more difficulties and challenges. So as you approach that, I think that you have to be knowledgeable about the lens design and knowing what you're seeing on the topography versus what you're seeing with the lens on eye, what you're getting with over refractions versus what you're getting with residual refraction. So, knowing how to use all these parameters, and most importantly, knowing how to communicate them with your consultation department and your manufacturers, I think is key. So it's important that we, I think going forward, maybe have a little more foundation or basis on established nomenclature so that we can communicate what we're finding a little bit more easily, but also so that we all understand what we're seeing, what we're finding, and then troubleshooting it. So yes, the empirical fitting is really easy and it's useful, but the more fits you do, the more knowledgeable you have to be. So I think it's really important that we inform ourselves so that we can work closely and better serve our patients.
Well, Jane, I've got a little twist, and it happened several years ago. One nice thing about empirical fitting is there's no cost to do it, other than you get certified and you're ready to start working with the lenses. I could still remember years ago pulling out a lens out of a vial and putting on a patient. It looked perfect, and at that point, I thought, if the lens looks good, I'm dispensing it to the patient that day, and I'll just reorder for the lens. Well, the mother was taken back a little bit. It's like, well, how specialized is this lens if you have it sitting in your office? So I did a 180 and kind of I still did the diagnostic lenses on the eyes, but I said, okay, now I'm going to customize it even further and make it specific for your needs, and we'll get it back to you. And then we ordered the new lens exactly the same as the diagnostic. But having the diagnostics actually backfired in that one patient because she didn't think it was a customized lens at all.
Well, let's panel, if you're in for it, let's get to some of these questions because I'm seeing a bunch of good questions here. Let's see. Do you usually phone in empirical orders? Do you email everything in? Do you order it yourself? Do you have staff do this? Anybody want to, we're talking about a little practice management here. Anybody got some feedback for him?
I can take a shot at it first. So, if you haven't noticed, just based off this, I like to talk a lot. So I usually like to call the consultants. I just love talking with them. I like having that personal kind of connection with the consultants. Most of the time, especially with the labs I work with, I can call them and just say my first name and they know my account number. So I like that aspect. I like talking with them. And then when it comes to troubleshooting later on, I like talking with them and being able to like work through, all right, here's what I see is going on. Here's what I think we should do. And they can either tell me, yes, you're right, way to go. Or they're like, nope, you're wrong. This is what we want to do instead. So it helped me to expand my own knowledge, especially, hopefully 20 years down the road, I, am a little bit more knowledgeable, but to start off with, I'll take any help that I can get. So.
Yeah, I always say the consultants at whichever lab you're working with, but certainly at Euclid, there's nobody who understands the subtleties of the Euclid algorithm and designs better than those people, because that's all they work with. All of us, we work with hundreds of different products and we need to know a little bit about all of them. They only have one area of expertise and they're really good at it. They still point me in the right direction, I think. So, you can do it however you feel comfortable. I think that's kind of, you can turn it over to the consultants, you can get involved, you can use it as a learning. I think that's really good. I had a question here about, has the FDA approved overnight orthokeratology for the use in children? I will answer that. As far as our Euclid approval, there is no age limit in the US. So you can fit adults, you can fit teenagers, you can fit children. In other countries, and we do have people on this call tonight from other areas listening in, there are age limits in approval. I know in mainland China for one that the age is no child under the age of 8 is to be fit with, that's just their government. And it varies from place to place. So if you're outside of the US, look to your government for their approval. But here there's really no age limit. But what's the youngest child any of you have ever put in OrthoK?
Ours is 6, Jane.
Yep.
6 as well.
Yep.
Old 5.
Yeah. Ooh, an older 5. I got to tell you, don't like doing 6-year-old, but I have done them.
I had an older sibling, so it's
that makes a lot of difference.
Yeah.
Well, we also know that some 6-year-olds are more mature than a lot of the 15-year-olds that we see.
Oh, yeah.
Hey, Jane, we've got a wonderful question. It's, how do you convince these patients that increasing myopia can be a significant problem for them? I discuss this with most patients and have an OrthoK brochure I provide, but only have 2 patients in OrthoK and 2 others in atropine therapy. I don't want to scare them, but they seem to be totally blowing this off.
That's a good question.
Jane,
Anybody want to answer?
Jane, could I jump in on that one?
You sure can, Barry.
Doing it for a little bit of time. So this is something that doesn't happen overnight. This is a culture that you have to build over time, just like any other area in your practice. And that message has to be consistent and it has to be pervasive. It has to be in many different areas. So we share the concerns about myopia and its implications across materials that we do on our website. We do it with email blasts. We do it in-office materials, and we do it one-on-one with patients. We've put together various brochures, not only brochures, but even folders with information on that. And we have all the references that are there for those who want to, really get down and dirty with research if they really want to do that. But it's a consistent message. Your staff has to have it. The doctors have to have it. And it does take time to build that. There are some individuals that come in already, quote unquote, pre-sold. And we have a large contingent of individuals and families that are already concerned about myopia before they even speak to us. But there's another group that really needs that education. And a lot of times it's a matter of planting the seed. So sometimes we'll see a young individual who we're starting to see signs of progressive myopia or documentation of progressive myopia. We have that conversation with the family, with the parents and the child, and they may not be ready to make that move this time. And sometimes we'll say, you know what, let's have them back in 6 months. We're going to repeat some of these baseline measurements, and we do axial length and cycloplegic refraction and all those sorts of things. And if we see evidence that really this is a trend, let's have a more serious conversation about the alternatives in addressing it. And surely, if the parents are myopic, and we know many of the cases that is this situation, they are often more concerned.
I have a couple of questions here. Kate, I think you mentioned, and I saw a couple of head nods with, you mentioned you use clear care. The question is, do you ask them to do a saline or a wetting solution rinse after clear care?
Jane, that's a good question. So I do not have them rinse with any particular saline afterwards, because after you've used your hydrogen peroxide solution, it should all be neutralized, and it's essentially saline that's in there. And I'm always fearful of like adding solutions and other things to the care system. So I like it to be effective but simple. Families have a lot going on in their lives, and the last thing they need is to pack 5 bottles of contact lens solution for the kids to take on vacation. So that's the reason I like the hydrogen peroxide solutions, because they're simple. What I do have my patients do with their lenses is put a thick drop, artificial tear drop in the lens prior to insertion. I find that keeps the lens a little bit more comfortable, and sometimes actually helps with the treatment as well. So just 2 things, clear care, and then also using that nice artificial tear in the lens prior to insertion. Simple, easy, and effective.
Somebody asked me about high E values or eccentricities or aspheric factors. If you see that, do you have any change to your fitting direction? Anybody pay close attention to eccentricity, or are you going strictly by K readings?
Well, Jane, I look at that factor. I'm more concerned about low E values in terms of not responding as well as higher E values, no doubt about it. I do believe that in the algorithm, if we could include that, that would just add to that 87. So as we were mentioning before, yes, over time, we're going to be adding more and more factors, the toricity factors, the eccentricity factors, and as I said, maybe even at some point, even some of our aberrometry factors, and maybe we can do aberrometry control, because we run aberrometry on all of our patients, and surely all of our patients that have Ortho-K done. And we all know that aberrometry can tell us a lot about what's happening in this particular treatment. Many of the patients who are 20/20 still have a significant elevation of high order aberrations. Some of the younger kids don't complain. Some of the older folks often do. So if we can account for that and maybe hone in our treatment to minimize some of those induced high order aberrations, we might be doing even better.
Yeah, that is one of the things. I'm going to go back to Trevor's comments. I learned very quickly because I was trained in keratometry, not eccentricity, and so it was kind of a mystery number to me. But by talking to the lab consultants, I recognized that when I sent them my topo and they looked at that if it was an unusually flat eccentricity, then they'd say, we probably need to change the alignment curves because you've got a much flatter than normal. And so they would make suggestions to me. So that is do we tell you to build something in? No, not directly, but our fitting consultants will look at that. If they see something, they will make suggestions for you to adjust your fit for that.
This was talking about choosing materials. So for the new product, what is the benefit to the patients compared to other materials? If there's no difference in infection or inflammation or corneal edema, why would they change?
The same reason we get new iPhones. They still make the same phone call, but it's just newer, better, and it's there. So we could say just the opposite question, I think, is even more valid. Why wouldn't you offer a better material to a patient? But it's philosophical that every practitioner has to answer. But for me, it's the better question is why wouldn't you offer it if it's the same and going to allow more oxygen? And we know more oxygen will be a little better, and chances of problems will be a little less.
I think also, Tom, to add to that, if we just use the analogy of what's going on in the soft lens world, right? The Sci-Hi versus hydrogel controversy, I think all of us would admit that if all else was the same, meaning corneal inflammatory events being the same, which they aren't, or wettability being the same, why wouldn't you want more oxygen, right? So I agree with you 100% on that. And there is some evidence that higher oxygen transmission equates to a better long-term health response. It's still not something that I feel 100% confident with, but there's some suggestions in those areas.
Yeah, we talked about a couple of studies there. The Swarbrick study that talked about it may cause for a more rapid change, but there's quite a few studies around in the literature that talk about reducing. We know we get some overnight corneal swell, but we want that to stay well within the normal range, because if not, it opens up those cell junctions, and that potentially gives us the chance for bacterial infections and those kind of things. So anything we can do to keep that cornea in its normal in situ state is what we want to do. We want our contact lenses to provide as little impact to anything that we can in that cornea. I had a question here and I wanted to touch on it. It said, so compared to Minicon Z, what's the difference? But I want to go back and make sure everybody understands. The original Minicon Z from 1996, the basic formula of the product is the same, but the variation that Contimac did had to do with improving what they considered the limitations of Minicon Z. They wanted it to wet better. They wanted it to be more durable. They didn't want it to flex as much. So by changing the polymerization and the percentages of the monomers in the mix, by changing some of the recipe, they developed and have a new product. This is the newer. So compared to the old Minicon Z, that's what you've got. You've got these newer versions of it. So, even though they all carry that same USAN name, they are, we're talking about from 96 to 2021. There's a lot of differences in those materials.
Jane, we had another question that was pretty good.
Yeah?
And he asks, are you using tangible HydroPeg? And is that an option, practitioner?
Anybody using HydroPeg on OrthoK? I see a bunch of no's. Tom, do you use HydroPeg? You're hiding behind my question.
No, I do not.
Okay. Yeah, I have to say, HydroPeg is a supplemental that many labs offer treatment for materials who have wetting issues or patients who have material wetting issues. We do not offer tangible HydroPeg at Euclid and don't recommend it. Don't feel like you're going to need it. So Euclid Max, as you've seen it presented tonight, has no plasma or surface treatment with tangible HydroPeg. Somebody asked me if can the treatment zone be adjusted in Euclid lenses? Anybody want to? One, you got to figure out what treatment zone is, right? You can adjust the diameter of the posterior optic zone, certainly. You can adjust the applanation zone by changing the reverse curve, making more sagittal depth or less sagittal depth. So yes, you can make all those changes. You just have to decide. You have to let us know what it is you're trying to change, why, and then we'll help you find the best road to get there. I hope that answers that.
We've got another one. This is asking about the DK of 180. Is this by a gas to gas method, or is this using a different method?
Oh, let's look on that chart, Laura.
Hold up.
Pull that chart up, because I honestly don't know right off the top of my head. You know, that those DK values, while she's doing that, let me explain. DK value vary across the production of what we in the polymer chemistry group call the rod, or the raw material. You know, this starts as a liquid, and it's, you know, it's polymerized, it's cooked in some process to harden it. Now, when it hardens, it's usually in a rod shaped form. That rod, from the top to the bottom to the middle, has slightly different variations. And so what the plastics production people usually do is they take samples from different places, and there's an average number there. Now, with the DK of 180, because there had been a lot of variations in DK reported for tisophilicon A through the years, you've seen 200, you've seen 163, you've seen, I mean, there was just numbers all over the board. So what we did is we did several different testing methods to come up with the one that the FDA allowed us, which is that 180 number. So.
And Jane, this is using the ISO-FAT method.
There you go. Thank you, Laura, for looking that up for us.
You're welcome.
Let's see. If no cost, if wrong fitting, free to change. We'll talk about that in a minute, Jen. Reverse curve. If the reverse curve width is still 0.5 diopters.
0.5 millimeters.
Yeah, not diopters. You're talking about, if she's asking, is the standard reverse curve? Yes, the standard algorithm reverse curve would be, you know, a certain width. However, we can change that. If you need if you want a wider reverse curve, or I don't know why you'd want a more narrow one, but yes, you can do that. I think that's what that question was about. Somebody's asking me about a higher myopia. Of course, in the US FDA, the approval is to a refractive 5 diopters. I always say that's after vertex, but you know, so I can't comment on anything higher. Maybe, you know. And we didn't say this at the beginning of this. I want to make sure everybody understands that our panelists tonight have been expressing their own opinions. These may not be the exact approval of a Euclid product or our company direction. These are their personal opinions. So I wanted to make sure that you guys, we had that. Okay.
Jane, would you like to tell us a little bit more about the satisfaction guarantee that we're offering?
Yeah, it's getting time to do that, isn't it? There we go. Hang on. I'm just looking. If you scan through all these questions, there's a lot of questions here. So we're trying to hit all the different topics for you. A lot of them have to do with combination therapies, you know, and again, that's kind of open for all kinds of things. Let's wrap this up because we're getting late and I appreciate everybody's time. So, you know, I wanted first to mention that we're going to be doing this same general discussion tomorrow night, starting at 9 o'clock Eastern time. We adjusted it later for hopefully our West Coast accounts can join us more easily. It will be with a different panel of experts. So if you've enjoyed tonight, but you'd like to hear some of it again or have 4 more opinions, please join us again tomorrow night. Let me tell you that orders can be placed tonight or anytime now by contacting our orders at euclidsystems.com email or calling us. The No Max and Max Toric have what we call a no risk, 100% satisfaction guarantee. You know, we believe we are confident enough in this material and this brand to tell you to just try it. Give it a try on your next patient. If you do not, or if they do not like this Max, we will gladly replace it for you in the standard Euclid Emerald or Emerald Toric product line for you. So there's nothing to risk. Give it a try, see what you think. And if you're new to Euclid, if you're just getting certified and opening a Euclid account, then at Euclid, your first pair is always at no charge as a welcome gift from us. And that can be in Max or in Emerald design. So we hope we take some of the pain of trying something new out of this for you. And you'll, utilize our no risk guarantee. I want to wrap things up and say a final thank you to our panel, Dr. Barry Iden, Dr. Thomas Finley, Dr. Trevor Faso, and Dr. Kate McClure. Those of us involved in industry, we can say whatever, but the truth comes from you. We appreciate you being honest with us and giving us your opinions tonight and answering our questions. So we look forward to it. And thank you to all of you for spending your evening with us and asking these wonderful questions. And please stay in contact. Contact any of us at Euclid and we'll be glad to answer your questions, or you can contact your local Euclid sales representative for more information on pricing, on policies, and utilizing this product in your practice. Thank you, everyone. Have a wonderful evening.